respected chairpersons, seniors, especially Dr. Mohabbat, good to see him again, and my dear colleagues. So, what is neuromodulation? By definition, it is, the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body, depending on the pathology and the need of your treatment. So this is the basic definition. Now, if we extrapolate this to, say, any neuromodulation for today's topic, spinal neuromodulation, we can divide it into two broad groups again. One is electrical and one is chemical. In electrical, you have spinal cord stimulation, mainly or rather ethically used for pain. Then sacral nerve stimulation, some people consider it peripheral, but because you access the S3 through the spinal foramen, you can stretch it into this. And in the chemical group, you have intrathecal baclofen pump, intrathecal morphine pump, the first for spasticity and the morphine pump for intractable pain, especially oncological pain. But because of the theme of today's symposium and with respect to time, I will concentrate my talk today on my experience with spinal cord stimulation for pain. And I would like it to be an interactive session because I face many problems doing this, and would be glad if I get some answers from the august audience. So, coming to the basics. So, pain is it's just like there's a plethora of pain disorders. So, first and foremost, we have to pick up the right patient. For that, our basic, is this the marker? So, two important words, neuropathic and chronic pain. So, for any neuromodulation to succeed, the pain has to be ascertained as neuropathic. I will not go into the base definitions because the august audience is enlightened to it. Two words, chronic pain lasting more than 3 to 6 months, and it has to be neuropathic. Now, this cluster of pain, chronic neuropathic pain, is a tough nut to crack. There are various ladders and algorithms explained, but many cases, the last resort always falls on neuromodulation. So there has to be a sort of a running protocol. Different institutes have different protocols. In our pain clinic, what we follow is the patient with a chronic neuropathic pain should have at least tried judicious use of pain medications, physical therapy. Once these two are exhausted, not less than 2 interventions, whether it be a block or a corrective surgery. If these procedures fail, then the patient's, after ascertaining he has a neuropathic pain which is chronic, becomes a candidate for neuromodulation. And coming to the spinal cord neuromodulation, again from the same protocol what we discussed in the previous slide, there are two main syndromes which fall into that category. One is the failed back syndrome, which, Dr. Mohabbat has an objection with the term, but it is mainly, as you rightly elucidated in the previous discussion, it's mainly an improperly selected patient or an improperly done or overzealously done fusion, rather than, a simple failed back surgery. So it's again goes back to the patient selection and the procedure selected. So that is one of the major indications for chronic neuropathic pain spinal cord stimulation. And second is, of course, CRPS type 1. The mechanism of action, it's still fuzzy. So there are various hypotheses which runs from stimulation of the dorsal column leading to gait control, increase in the concentration of the inhibitory neurotransmitters and decrease in the concentration of excitatory neurotransmitter with chronic stimulation, increased activity of the inhibitory interneurons, and also some supraspinal mechanisms which are implicated for the success. But the jury is still out regarding the exact mechanism of action, but it does work in properly selected cases. Now, why not an ablative surgery? Why such an expensive surgery? So there are definitive advantages. Not only it is a non-destructive and less invasive surgery, that is a given, but it is reversible. And if the pain increases or pain relapses, we can reprogram the device and go one up over the pathology. Foremost, it provides you with a scope of a trial. Before you commit to the final therapy, you can have to do a spinal cord stimulation trial, which gives you an opportunity not only to gauge the patient response, the coverage area, as well as the response of the pain. It also provides an adjustment period of say around 5 to 7 days. And we have a thumb rule of a 50% reduction in pain in say a visual analog score. If there is minimum of 50% reduction at the end of the trial period, then you can counsel the patient that he is a reasonable candidate. Still, you can't predict 100% success, but you can say he is a reasonable candidate for a spinal cord stimulation. The dilemma starts here. What will you put? A percutaneous lead or a paddle lead? Now, my practice over the last 12 years has shifted, and now it started with purely percutaneous and now it is purely paddle because of these very reasons. Unlike a percutaneous lead, a paddle lead provides less scope of lead migration. It's anchored to the dura. You can connect it with, stitch it up with the surrounding connective tissue. So, because the migration is less, there is less positional variation. And the footprint of a paddle is much greater. It gives you a better footprint, you can have a better coverage with a single lead. What I do in my trial periods, I use a paddle and then connect it with an extension wire. The extension wire is the one which is exposed outside for the trial. So if I get benefit during trial period, I don't have to take out the trial lead. I will keep the trial lead and just remove the extension wire and hook the trial lead with a new extension wire and internalize it. So there was always a danger with percutaneous leads that once you have a good trial, when you remove it, there is no guarantee once you are putting the final lead, you will hit the same spot. But a paddle lead negates that possibility. And of course, if you are doing a small laminectomy going in, an epidural scar is a predicament to the infiltration of the current into the dorsal column. So you can clear the epidural scar and hope for better efficacy of the spinal cord stimulation. So various reports are there in literature which confirm these advantages. We had our experience from Vedanta published earlier this year in AJNS. And it also verifies that paddle lead has got definite advantages over percutaneous cylindrical leads. Technological step is the simplest of all surgery which anyone can perform. So you just have to do a small laminotomy depending on the area where you want the spinal segments to be covered. For example, here I have put a quadrupolar lead on a cervical for a upper limb CRPS. Here there is a dorsal paddle lead 565 configuration for a failed back syndrome. So the spinal segments you select according to the clinical the distribution of the pain. Under fluoroscopic guidance, we put the lead. It's a very simple thing. Do a small laminotomy, clear the epidural scarring, and just put it. The laterality you can adjust a bit. Suppose it's more unilateral, you have to shift towards one side of the center of the axis. That small adjustment, the simple adjustment you can do during the procedure. Once you have a successful trial period of say, at least 50% reduction in pain, the second stage after 5 to 7 days, you internalize the system, take away the old extension wire and connect the paddle lead which you have used for the trial with a pacemaker and internalize it, and that's the end of the surgery. Programming strategy, I usually use wide bipolar combination so as to have maximum pain coverage area, pulse width of around 210, rate varies depending on the response, and I tend to have different programs for different activities. There's a reason for it, I will come to that. So my personal experience, limited though, 31 cases, 23 were failed back surgery cases and 8 were CRPS type 1. The point here I want to make is, it's very all hunky-dory and rosy for the first 2 years. Patient will come to a follow-up and say, I'm doing fine. Problem starts after 24 months. As you can see, there is a sharp increase in the visual analog score scale after 2 years follow-up in my cases. So at the latest follow-up, the average VAS was 4.1. So patients are not doing that well, which they were doing at the start of the surgery or even up to 2 years. So this is something which I'm sure with doctors who are into spinal cord neuromodulation, this is something which is nightmare for us. The effect diminishes with time. There are various causes for that. Causes and hypothetical causes like maladaptive neuroplasticity, disease progression, diminution of placebo effect. But once you rule the obvious complication of lead migration and everything, you come to a point where you have to do something to the patient. There are some strategies which you can do, like periodic fine-tuning of programming parameters, set different programs for different activities to negate habituation, on-off strategy, burst spinal cord stimulation. There are certain newer innovations coming up, like high-frequency stimulation, not yet in India, and specific dorsal root ganglion stimulation for patients who were now refractory to even spinal cord stimulation. So what does the evidence say? I'll just conclude it in a short one, 30 seconds. So on long-term utility of spinal cord stimulation, there is the plethora of literature. But there are two meta-analyses which I want to point out. One is by Duarte et al. In 2020. The conclusion was conflicting in long-term efficacy. Up to 6 to 24 months, it was good, but in long-term, there were low to moderate quality evidence to say what happens after 5 years down the line. And most others who were in these trials had conflicts of interest, industry-based. Another meta-analysis, which had 12 randomized control trials in its parlance. See the last line. 11 of the 12 studies were industry-sponsored, who told that the relief is more than 24 months. The only study which was non-industry sponsored, they said that the nerve stimulation method, they didn't find any difference compared to a traditional method or using an advanced spinal cord stimulation. So you can see the gray area. So if we have to have solid evidence based on which we predict to the patient that you will benefit this much and this is your prognosis, we need to have evidence also. And at present, till 2020, most studies are industry-based, industry-sponsored, and that leads to a great bias in concluding and confidently relating the outcome to the patient. Nevertheless, despite everything, if you have a good case selection, the results can be marvelous as well. The case in point is this present study. I will conclude my talk with this study. The 40-year-old gentleman was suffering from CRPS type 1, and it was so severe. It started on the left, marched to the around the neck and to the right upper limb, that he had developed reactive spinal myoclonus. Everything has been tried on him. Then after evaluation in our pain clinic, we offered a retrograde high cervical C1, C2 approach, paddle lead, and not only was he free from his pain, and we have now a follow-up of 72 months, because the pain went away, his reactive spinal myoclonus also disappeared. So these are some videos. You can see this patient was having such severe pain of CRPS that it was like a miserable life. Just to touch, a simple touch, he will throw into this vigorous spinal myoclonus. And this is the patient during the trial period, the second day of trial. You can see I'm touching him, there is no myoclonus, and the patient is quite happy with it. And next. Sound to this video. So there is a patient testimonial to this. Then I will skip it then. So the patient is saying that
about a week back with complaint of excruciating pain in both his upper limbs and the back side of the neck area, which he has been suffering for the last 12 years following a road traffic accident. Pain was severe, so much so that even to light touch, a feather touch, or the touch of a clothes, it will initiate violent jerks or involuntary movements. Like he will be ferociously throwing his upper limbs back because of this very rare but excruciatingly nagging disease, what we call as complex regional pain syndrome.
डॉक्टर से मिले पण वो कोई इधर भेजता था, कोई किधर भेजता था, उनको समझ में नहीं था कि भाई अपन करे क्या। सर के पास आए तो उन्होंने समझाया सर कि देखो इसमें
With all due respect, Dr. Judeja was also one of those doctors. He gave him temporary relief with peripheral stimulation, but then couldn't carry on further.
ऑपरेशन चला हो, और उसके बाद मुझे अभी तक जाने आया 6 तारीख के बाद, तो जो मेरा टच सेंसेशन था वो 80% रिड्यूस हो गया है।
The retrograde high cervical spinal cord.
So I'll maybe
It's a pioneer
on the video.
in India.
And conclude. So this case study was published in the BJNS, and coming to the conclusion. So spinal cord neuromodulation for chronic pain is on the upswing, but the most important thing is proper patient selection. The thing which I am being plagued with is someone give me some thoughts or some strategies to prevent the temporal diminution of effectiveness. And there should be proper clinical trials which should be industry independent to give honest outcome to the patients. And of course, with better understanding, neurophysiological understanding of the pain pathology and improvement in technology, we will have better results in future. These are some references. Thank you.
Thank you. Wonderful presentation.